Welcome everyone. Today we'll be talking about respiratory system. So we'll be discussing about asthma, COPD, pneumothorax, pneumonia, and those kind of disorders. So first, to differentiate between respiratory disorders, it can be an obstructive, it can be a restrictive. Here, FEV1 starts from forced expiratory volume in a second. So how much you can expire out in a second forcefully. FVC stands for forced vital capacity. If you take a deep breath and hold it in, how much can you take a deep breath? That is forced vital capacity. The ratio usually is 70 to 80%. So you're able to expire around 70 to 80% of the forced inspired air in a second. This ratio comes down in an obstructive airway disease. This ratio remains in the normal range because both FEV1 and FVC comes down equally. So in restricted airway disease, it remains normal. Unlikely questions appears on this. This is more often primary, where they are fond of asking those questions. So now we'll go in more important stuff. We'll first talk about asthma. Asthma, we'll be talking about adult as well as pediatric side by side because they are quite similar. There are only few differences, so it will be easy for you to remember from exam point of view. Asthma, acute exaggeration of asthma. You are not diagnosing an asthma in emergency department. If someone comes worsening of the asthma, that is acute exaggeration of asthma, how do you treat it? First, before treating, we need to classify it. Is it moderate, or is it acute, severe, life-threatening, or near fatal? One thing which is important here is bedside investigation, peak expiratory flow. Peak expiratory flow, if it's between 50 to 75 or somewhere more than 50, if you can take it, then you call it as a moderate acute exacerbation of asthma. If it's between 33 to 50%, then it is acute, severe, life-threatening will be less than 33%. Okay. Rest of the parameters remains normal in moderate acute asthma, and they will be able to talk in full sentence. Here in acute severe asthma, they will not be able to talk in full sentence. Along with it, respiratory rate will be equal to or more than 25, heart rate will be equal to or more than 110. Okay, these features are important. You need to remember so that you can differentiate. None of these features are present in moderate. These features are present in acute severe asthma. In life-threatening asthma, two things you need to remember numerical wise, that is peak expiratory flow will be less than 33% and oxygen saturation will be less than 92%. Okay, basically hypoxia on ABG, normal PaCO2 will be there. Rest of the clinical signs are easy to remember because you're getting exhausted. There is retention of carbon dioxide. As you are getting exhausted, your respiratory efforts will become poor, just will become very silent because no air is entering in. Sinuses will start creeping in. There will be hypotension, which might lead to arrhythmia. As carbon dioxide is getting retained, there might be carbon dioxide narcosis leading to low levels of GCS, hence altered consciousness level. Near fatal. Near fatal is you are about to get arrested. There will be respiratory arrest at any point of time. When do we call it as a near fatal asthma? Whenever you see an carbon dioxide level more than the normal, that is PaCO2 levels are high. It is primarily a type 1 respiratory failure, or primarily you're just seeing hypoxia in asthma. But whenever you are seeing a carbon dioxide retention, that is raised PaCO2, that means you need to be doubly aware that this patient is worsened and this patient can arrest at any point of time. Most likely this patient requires endotracheal intubation and needs to be put on mechanical ventilator. Otherwise, any point of time he'll go into respiratory arrest and die. Intervention is required immediately in near fatal asthma. The classification in children is again very much similar to that of the adult. First, we'll be seeing the PEF. PEF in moderate, it will be more than 50%, as mentioned here. Here it will be 33 to 50%. Here it will be less than 33%. Similar to adult, no changes. SpO2, obviously, it will be more than 92% here. Again, no changes. Okay. These changes here are quite specific. You shouldn't, it's quite similar to what's given here. That shouldn't be a problem. One thing you need to remember is oxygen saturation less than 92% itself. It comes in acute severe asthma. Here it comes in life-threatening asthma, not in acute severe, life-threatening asthma. Heart rate and respiratory rate changes according to the age. That's why they are given separately for the age more than 5 years and 1 to 5 years. Okay, it's not very important to remember the heart rate and respiratory rate from exam point of view, but the oxygen saturation levels, PEF values are important. Especially the oxygen saturation is important. It causes acute severe asthma in children if it is less than 92. If it's less than 92, it causes life-threatening asthma in adults. When to get a chest X-ray done? Every asthmatic patient who comes to the emergency department doesn't get an X-ray done. It's not always required to get an X-ray done. You get an X-ray done if you're thinking that there is an infection which is causing acute exacerbation of asthma, or you're thinking there is a pneumothorax or pneumomediastinum, or you're given in medical management, still the patient is not improving in spite of giving the treatment, you're not sure what is happening, then you get an X-ray done. Whenever there is a requirement for ventilation, ventilator is required, ventilator support is required, then you go ahead and take an X-ray done. All life-threatening asthma patients requires an X-ray. So not every patient who comes with moderate or severe acute exacerbation of asthma needs to get an X-ray done. There's few indications where you need to get X-ray done. Depending on this, you will get an X-ray done. Not always, or not every patient gets an X-ray. What about arterial blood gas? Arterial blood gas only if the oxygen saturation is less than 92%. If it's more than 92%, or there's no requirement of oxygen, don't get an arterial blood gas done. It's a painful procedure, don't get it done. Every patient who comes to the emergency department with an acute exacerbation of asthma needs to get a peak expiratory flow. It is a device which looks like this. This is the mouthpiece. You need to take a deep breath and blow it through it. It gives a reading. Okay, this reading is very much helpful for classification. This is the PEF what we are talking about. It's very helpful in classification, and also we can monitor if they're improving for the management what you're doing, for the treatment what you're giving. Are they improving or not? You can quantify using a peak expiratory flow. So every patient needs to get it done. Treatment differs between adult and children. So if any patient who comes to the emergency department who is has an asthma and acute exaggeration of asthma, you're thinking, if there is oxygen requirement, give them the oxygen. After giving oxygen, you will be giving an beta-2 agonist, that is nothing but salbutamol. Okay, usually moderate exaggeration, moderate asthma, then you give puffs. You can give 4 puffs, not improved, 2 more puffs, 2 more puffs. Puffs should be sufficient. That is you can use an inhaler. If it is anything severe than moderate, like acute severe or life-threatening, that's when nebulizer is required, and usually nebulizer should be given through an oxygen. Okay, oxygen-driven nebulization should be given. 5 mg is the dose what we'll be giving. If there is no improvement, you can start giving back-to-back doses. Okay, if bolus not responding, then you can continuously give. Usually we give it back-to-back 5 mg, 5 mg, 5 mg. You can keep staggered doses can be given. When do we give ipratropium bromide? Ipratropium bromide is usually given in severe or life-threatening asthma, or they're poorly responding to beta-2 agonist, what you're given here. That is poor response to salbutamol. The dose is 0.5 mg, and you give it only every 4 hours or every 6 hours, 4 to 6 hours once. You can't give it back to back how you give beta-2 agonists. Magnesium sulfate nebulization is not recommended. It is not. It is recommended in children, but not recommended in the adults. Everyone gets steroids. Steroids reduces the mortality, relapses, and hospital admissions. Hence, everyone gets steroids. Oral, it doesn't mean that IV steroids are superior than the oral steroids. Both are equal or has equal potency. So you can give orally if we can take orally. So preferred one is oral prednisone, usually around 40 mg, given minimum for 5 days or till the symptoms to subside, whichever is earlier. Sorry, whichever is later. If inhaler techniques, that is in both beta-2 agonist and ipratropium bromide nebulizers are not working, then you give magnesium sulfate IV. Okay. That's when you go ahead and give IV. Usually we end up giving 2 grams itself over 20 minutes. Aminophyllins, don't give it unless you have consulted in just physician consultant. Antibiotics are not required unless you're thinking it is an infection which is causing the acute exaggeration of asthma. Don't always give antibiotics as a routine. Examine and see. Most of the time, it's not the infection which is triggering or worsening the asthma here. NIV is not preferred in asthma, mainly because of air might get trapped in and causes hyperinflation of the lungs. Okay, that is known as dynamic hyperinflation can occur in asthma as discussed in cardiac arrest scenarios in resuscitation chapter. Thus, the reason NIV is not preferred, we most probably go directly to a mechanical ventilator. So ET tube will be inserted, put them on mechanical ventilator. NIV is not recommended or not preferred according to BTS guidelines in adult patients. What about children's? Children's, again, it is same. Beta-2 agonist is the first line of drugs. If oxygen is required, we will give oxygen. If oxygen is not required, then you will be going ahead and giving beta-2 agonist. Usually preferred is to give it through an inhaler with an pacer. This is known as pacer. Okay. Most of the, especially the smaller kids who are like 4 years, 3 years old, will not cooperate for the nebulization full time. So giving through an inhaler with a spacer is a better technique, especially in pediatric age group. But in severe cases, you can go ahead and use nebulizers. The dose is usually 2.5 mg. You can use it. 0.25 mg is for ipratropium bromide, what we'll be using if beta-2 agonists are not working. Again, beta-2 agonists can be given back to back if they are not working. Another inhaler you can add up if beta-2 agonist is not working is magnesium sulfate. 150 mg can be given for these patients, especially if it is acute severe asthma and saturations are less than 92%. Everyone gets prednisone similar to adults. Depending on the age, the dose differs. You might not remember. You can just remember according to the local protocols. I'll give it. It's not important to remember the doses. If these inhalers are not working, then the first preferred IV drug is magnesium sulfate. Salbutamol also can be given in the IV form. Aminophyllins, as in adults, you will only give it after discussion with a consultant. You will not give it on your own. So preferred IV drugs are magnesium sulfate and IV salbutamol here. The 3 nebulizers here, that is salbutamol, ipratropium bromide, and magnesium sulfate. Everyone gets steroids. Same thing here, everyone gets steroids. Only 2 nebulizers here, beta-2 agonist and ipratropium bromide. IV drug, preferred one is magnesium sulfate. Aminophylline, you're not keen on giving it. You will ask the consultant before giving it. It's similar in children's also. So when to admit the patients and when to discharge the patients. Admission criteria for both adult and child is same. You admit anyone who has features or who has presented with life-threatening or near-fatal asthma. In pediatric age group life-threatening, there is no near-fatal asthma. Admit with any features of severe asthma, they are persistent in spite of giving medical treatment. When do you refer to an intensive care unit? If they require an ventilator support or there is a severe or life-threatening asthma, they're not responding to your treatment at all. That's when you need to refer them to an intensive care, that is an ICU. While discharging an adult, make sure the peak expiratory flow is more than 75% of the best predicted value. He has enough inhalers and there is an appointment. Inform that primary care within 24 hours of discharge from the emergency room, follow up an asthma attack. So they need to follow up with the GP in next 24 hours. So tomorrow you need to follow up with a GP. I'll give a call to the GP to get you an appointment. So you will help them to get an appointment with GP in next 24 hours so that they follow up and see everything is going fine. What about child? When can you discharge a child? Child should be stable. That means all his vital parameters should be stable, especially his saturation should be more than 94%. And the requirement of inhalers should be every 3 to 4 hours or more than every 3 to 4 hours. It shouldn't be like every 2 hours he is requiring inhalers. If he's requiring inhalers every 2 hours or 2.5 hours, then you'll admit him. The peak expiratory flow value should be more than 75% of the predicted value, as said here, similar to the adults. SpO2, as I told you, should be more than 94%. It's nothing but the patient should be stable. When discharging, everything should be written and given. Make sure there is sufficient inhalers, similar to adults. They have to meet up with their GP in next 2 working days. And this is important, next 2 working days, because they keep asking questions on this. And in a month, can refer them to an asthma clinic at an usually about a month after admission. Usually after admissions, we refer them to the asthma clinic so that they can follow up. They tend to test exams already tested previously in exams. So remember this. So you need to remember when to discharge, when to admit, what are the drugs you can use it. What about COPD? Stands for chronic obstructive pulmonary disease. This is a type 2 respiratory failure. Asthma was type 1, this is type 2. In type 2 respiratory failure, there is carbon dioxide retention. That means PaCO2 levels will be high. So how do an acute exacerbation of COPD patients present? There will be increased shortness of breath, there will be increased respiratory rate, pressed breathing will be there. This is what you are seeing here. Lips will be pressed and they will be breathing in and breathing out from here. They'll be using all their accessory muscles. Because of retention of carbon dioxide, they will be having acute confusions. Cyanosis can present there. A new onset of peripheral edema will usually be suggestive of a left ventricular failure. It's because of increased resistance for the flow of the blood in the lungs, resulting in call pulmonale. Call pulmonale is nothing but COPD resulting in right ventricular failure. Features of that might be an peripheral edema. Marked reduction in the daily activities. He will not be able to carry out his daily activities. These are the usual presentations, and there will be chronic visitors to the emergency department, because once a COPD is always a COPD, will end up having multiple episodes of acute exaggerations. So we always get an X-ray done in a COPD. Why? Because infection is one of the most, if not always, the predisposing factor for an acute exaggeration of asthma. So always get a chest X-ray done. Chest X-ray classical features in COPD is barrel chest. You can see it looks like barrels. Along with it, you can see a tubular heart in between. So flat diaphragms, barrel chest, tubular heart are the classical findings what you see on chest radiography. Every patient gets an ABG done because these patients retain carbon dioxide. It can cause respiratory acidosis. ECG, you never know, there might be a cardiac thing which is happening. Just to rule out a cardiac thing, better to get it done. Because it's an infection, pneumonia, curb score will be required. That's why we are getting full blood count, urine, electrolytes. If they are on theophylline, get theophylline levels, because therapeutic index is very small here. That's the reason you need to get it done. Sputum cultures, blood cultures is required if you're planning to admit these patients, because you'll be starting on IV antibiotics. Always before starting IV antibiotics, you need to collect cultures. So collect sputum cultures and blood cultures. Usually this patient will present with using of accessory muscles, increased breathlessness. There is a worsening cough associated with yellowish color sputum, suggestive of an infection. That will be the classical presentation of an COPD patient. How do you treat this patient? If oxygen is required, you will give, but make sure the oxygen saturations are between 88 to 92%. Why? This is because this patient's respiratory drive is dependent on the low oxygen levels. If this oxygen levels go high, the respiratory drive will come down and he might end up having more retaining carbon dioxide. So don't give oxygen if the saturation is more than 90 to 93%. It's okay to have 93%. It's 92% still okay. 88% still okay. If 87%, then only you plan to give oxygen and give a minimal amount required so that you can maintain the oxygen saturation between 88 to 92%. Okay. Otherwise, if you give them oxygen, you must have noticed, or you will notice in further, you will notice if you give oxygen that these patients will become more and more drowsy. Drowsiness is because of carbon dioxide retention. Carbon dioxide retention, increased levels of carbon dioxide retention will cause something known as narcolepsy, carbon dioxide narcolepsy. So carbon dioxide narcolepsy will lead to low GCS. Okay, then it becomes difficult to treat. So you're worsening the patient if you give more oxygen. Use inhaled bronchodilators, both salbutamol and ipratropium bromide can be given. Steroids, usually a slightly lesser dose compared to the asthma. There we are giving 40 mg, we are giving 30 mg is required. Antibiotics, everyone will get it because most of the time it is an infection which is causing it. Theophylline are not preferred. NIV is important. NIV is not preferred in asthma, but in COPD, it is important. When to start an NIV? You start an NIV when there is a persistent hypercapnia, that is persistent retention of carbon dioxide level in spite of giving optimal medical therapy. What is the medical therapy you're giving? You're giving steroids, you're giving antibiotics, you are giving bronchodilators, that is salbutamol and ipratropium bromide, and you have waited for 1 hour, still there is no improvement. That's when you will start on an NIV. Once you're admitted, physiotherapy will be required. If they fail to respond to the medical treatment at all, and if it's getting worse, there is carbon dioxide retention, low GCS because of carbon dioxide retention, then you might have to admit this patient in an intensive care unit. This completes obstructive disorders, which commonly presents. We are not diagnosing a COPD, we're not diagnosing an asthma. We're just treating the worsening of asthma or worsening of COPD in the AD. Remember that when it is worsening, that's when we intervene and we treat them and decide whether to admit or discharge on this. Anyone has any questions can ask me before we go into venous thromboembolism.
Assalamu alaikum, Dr. Amir.
Oh, walaikum salam.
I have a question about asthma patient. If patient parameter get deteriorated, can I try NIV or I should go to invasive intubation?
Usually the recommendation is better to go ahead with the invasive ventilation, invasive than non-invasive. Non-invasive, if you go according to BTS guidelines, they don't recommend going ahead with NIV, though most of them off records, they'll try NIV before they intubate the patient. But for exam purpose, and if you want to go according to the guidelines, directly go for intubation if they're not responding to the medical therapy. They're worsening, they're not responding, there is carbon dioxide retention, suggestive of a near fatal asthma, go ahead and intubate the patient.
Okay, thank you.
So the dose of beta-2 agonist in pediatrics is 2.5 mg, right?
2.5 mg you can give it. Again, it's not important to remember the doses, unlike say they'll test you on the doses. Half of the adults, usually we give it as a nebulizer, but usually in you can use inhalers and you can use up to 10 puffs.
Doctor, in COPD,
Yes, COPD.
we cannot give oxygen unless oxygen saturation below 88.
Yes, don't give oxygen. We are aiming oxygen to be maintained around 88 to 92%. If it's below 88%, like 87, that's when you give minimal amount of oxygen to maintain the oxygen saturation between 88 to 92%.
In between, okay, I will not give.
No.
Okay.
Assalamu alaikum.
Well,
In pediatric
Walaikum.
asthma,
Yes.
the priority to give oxygen, then nebulizer, then after that to give IV. Am I right?
Yes.
Okay.
First is oxygen.
for
Everyone who requires oxygen gets oxygen.
Yes.
Then you're trying
Okay.
3 nebulizers. First is beta-2
Okay.
agonist, then ipratropium and magnesium. Then you're
Okay.
thinking of IV.
IV. When we start by salbutamol IV before magnesium sulfate,
Can you repeat your question?
starting by IV salbutamol before magnesium sulfate, the priority for what of IV?
First line is magnesium sulfate. So priority will be given to magnesium sulfate. First, you're starting magnesium sulfate, still not working, then you can start an IV salbutamol.
Okay. When the role of hydrocortisone? When? During the nebulizer? IV
Everyone,
hydrocortisone.
IV hydrocortisone, you will only give it if the patient can't take it orally, because you need to prick the patient to give IV, especially in pediatric age group, because hydrocortisone and prednisone, their potency and efficacy is quite similar, and if you give it orally also, it's similar. That's why we tend to prefer giving prednisone syrups are available. So you can give a prednisone syrup for the pediatric age group. If they're not able to tolerate it, for example, they're vomiting continuously, or he's very drowsy, he can't swallow, you are afraid that this kid might aspirate, that's when you will give IV.
Because in ER, most of patients we give nebulizer, like a patient in acute attack, gives 3 shots of nebulizer plus IV hydrocortisone. If patient planning for discharge, according to severity, I discharge him with oral prednisolone. According to that, I'm asking.
Why do we give an steroid? Steroid doesn't act for around it takes around 4 to 6 hours to show any efforts. In acute, it doesn't have any, but on a long run, it helps to reduce the mortality, relapses, and frequent hospital admissions. So that's the reason everyone gets a steroid. This is not an acute treatment, just to think that they shouldn't relapse again. That's why we are giving it. That's the reason. If you give it an IV, it will not show any effects immediately. So no point in giving IV.
Depending on that, I give the patient if he has several attacks in last few days.
Whatever the attack is, there is no increased efficacy of giving an intravenous. Parental route is not better than oral route.
Okay, thank you.
Last question, Dr. Amin.
Yes, please.
Is there a rule for ketamine use in asthma management, as Tentinelli mentioned there?
We are going according to the British Thoracic Society guidelines. So ketamine, you can use it for an intubation purpose as respiratory asthma. It's a good bronchodilator. You can use it. Off-label, they're using IV ketamine also for bronchodilation, but it is not recommended by British Thoracic Society.
Okay, thank you.
Dr. Amin, can you give methylprednisolone?
Yes, methylprednisolone.
Yes, can you give it for the asthmatic patient?
You can give it methylprednisolone. You can give methylprednisolone. You can give hydrocortisone. You can give plain prednisolone also. The doses.
Which one is superior?
If you see the studies, methylprednisolone is superior. It acts much better on the lungs compared to other steroids. But we are still sticking in UK for prednisone because it's much cheaper than methylprednisolone.
What about hydrocortisone?
Methylprednisolone is better. The best steroid is methylprednisolone according to multiple studies. That acts the best on the lungs. It specifically acts on the lungs and it acts best. That's the reason methylprednisolone was preferred over any other steroids in COVID patients also. Coming to venous.
Yes. I have a question.
Yes, please.
Sir, if a patient present to emergency department with asthmatic attack with heart rate more than 140, so which drug is preferred? Salbutamol or?
Tachycardia is not a contraindication for using an salbutamol. I'm aware that tachycardia will cause increase in heart rate. Increase in heart rate here, it might be because of the worsening of the asthma. If he starts feeling better, that means his breathlessness comes down, the tachycardia might come down or remain the same because you're using salbutamol, which causes slight tachycardia also. And it's a transient effect which has the tachycardiac effect on because of nebulization. And nebulization acts more locally as you're giving as a nebulizer on the lungs. Still, it is a salbutamol preferred one, even though the patient is having tachycardia.
Okay, thank you.
Dr. Amin, there is role in severe attack asthma. There is role for Balmicort nebulization.
Which nebulization?
Balmicort, budesonide.
Again, we are giving it as a steroid. It's a budesonide. We don't prefer giving it. Okay, we are giving as an parental route, or we are giving as an orally. Still, budesonide is no. These are all guidelines from the BTS, that is British Thoracic Society. So what they are recommending, we are going. So it is quite followed in Europe itself. It's not restricted to UK. It's followed in Europe also, and they are quite good. And their recommendations are followed in NHS. So we'll stick to the BTS guidelines. Coming to venous thromboembolism. Venous thromboembolism can be an DVT, as COC here. and it can be an pulmonary emboli. So it can be an DVT or pulmonary emboli. That's the reason we're discussing both here. That's the reason DVT is coming in the respiratory chapter. The treatment is quite similar, so you can easily remember if you deal with it together. It is important to remember the scoring. Scoring is very important here. So it is very important you need to remember. It is everything related to the limb here, except few things like acute cancer. You need to remember treatment ongoing within 6 months or palliative treatment. There carries 1 point. Any immobilization of the lower extremity is 1 point. It might be because of paralysis, or any plaster. Bedridden for more than 3 days, or a major surgery in last 3 months, that is 12 weeks, requiring and general anesthesia or regional anesthesia, 1 point. Localized tenderness along the distribution of deep vein system, 1 point. Entire leg swelling, 1 point. Calf muscle swelling, 1 point. Pitting edema of that particular limb which is affected, 1 point. Collateral superficial veins, that means dilatation of the collateral veins. Previously documented deep vein thrombosis carries 1 point. If an alternative diagnosis is at least as likely as DVT, then it carries -2 points. If anyone who has 2 points, then DVT is more likely. You will directly go ahead and get a Doppler scan done. If anyone gets 1 point or less than 1 point, still you're thinking of a DVT, you can go ahead and get a D-dimer done. How to go about this investigations? So you're suspecting a DVT. As I told you, anyone who has 2 points, then you are directly going at with a Doppler scan. Less than 2 points, you are getting an D-dimer done. Okay. Then you are seeing the result of D-dimer. If it is negative, you have ruled out, so you need not break your head. Here DVT, this more than 2 points, so you're getting an ultrasound scan done. It is advised to get an ultrasound scan done within 4 hours. If you're not able to get a Doppler scan of the lower limb within 4 hours, then it is recommended that you immediately start on anticoagulants, and you must get it done within 24 hours. If it's a positive, then it is very easy. It's a DVT, you're treating as a DVT. If it's negative, then again, or you might have not gotten D-dimer done, or if at all, if you have gotten D-dimer done already, then you will see if the D-dimer is positive or negative. If the D-dimer is positive, then you will ask them to come back after 6 to 8 days and start the scan. If at all, if you're started on anticoagulants, stop the anticoagulants. Tell them to come back after a week's time. Then repeat the scan. On repetition, if it's positive, then you treat it as DVT. On repeat scan, if it is negative, then you rule out the DVT and think of some other differential diagnosis. Okay. So remember that first you need to do well score. If well score is 1 or less than 1 point, then you're directly getting a D-dimer. If D-dimer is negative, you are ruled out. If D-dimer is positive, then you are getting a scan done. Okay. In this scan, if it is negative, then you have kind of ruled out and you'll stop using it. But here where the well score is more and you're not able to get an ultrasound scan done immediately, or if you're able to get an ultrasound scan done immediately, if it is positive, then you have a diagnosis easy. If it's negative, then you will go ahead and get a D-dimer done again. Or if you're not got it done, you will get it done to see whether the D-dimer is high or not. If it is high, you're calling this patient back to get a scan done after 1 week. While you are waiting for D-dimer or while you are waiting for your ultrasound scan, if it is getting delayed, please start them on anticoagulation. Start them on anticoagulation, then you can stop it on later time. Treatment we'll discuss together about pulmonary emboli and DVT. Now we are talking about pulmonary emboli. In pulmonary vasculature, if there is a clot which is formed, it will cause and pressure over the right ventricle. Okay, because pulmonary artery, it will be blocking and pulmonary part of a branch of a pulmonary artery or pulmonary artery main branch itself. It will cause pressure over the right ventricle. If the clot is a huge one, it's a huge clot, the pressure will be so much that RV will be dilated along with RV and RA, that is right ventricle and right atria will be dilated. This is an echo finding. Okay. So let's see how this patient presents with. There is a clot here, so it will be painful. What's the characteristic of the pain? It is a pleuritic chest pain. Pleuritic chest pain in the sense, whenever he takes a deep breath, the pain worsens, it correlates with the breathing, it correlates with the movements. So it is a pleuritic chest pain. Some amount of blood might be there in the cough, patient will feel breathless, there will be some amount of tachycardia, some amount of increased heart rate, mild fever might be seen, might get confused for an infection. Cyanosis might develop if it's a big saddle kind of clot. Elevated JVP suggestive of an right ventricular failure. So basically in pleuritic chest pain, what you're looking out for, it has an Wells score. Again, it is known as modified Wells score. Again, it is very important. Questions do appear on this, either on this or now DVT. There will be one question. I don't want you guys to lose points here. Signs and symptoms suggestive of an DVT as in Wells score, like in swelling of it or palpation. So that itself will carry 3 points. An alternative diagnosis is less likely, or you're thinking PE as and most likely diagnosis in this patient, that itself carries 3 points. Heart rate more than 100%, 1.5. Immobilization for more than 3 days or any previous surgery in the 4 days, 1.5. One more 1.5 is previous documented history of DVT or pulmonary emboli. Hemoptysis 1, malignancy on treatment or treated in the past 6 months or palliative. It's kind of similar to DVT what we studied. It's 1 point again. This scoring is important. If a patient has more than 4 points, directly go ahead and get an CTPA done. 4 points or less than 4 points. 4 or less than 4, you are getting an D-dimer done. This is an important Wells score. There is one more score known as PERC score, which stands for PE rule out criteria. So what is PE rule out criteria and when to apply it? You have a patient, you're not thinking PE might be the diagnosis here, but he is having a pleuritic chest pain. I don't know what to do about it. It might be a PE. It's one of the differential diagnosis, comes way below what to do about it. Use an PERC score. If PERC score, if all of this are present, that means age is less than 50 years, heart rate is less than 100, saturation is more than 95, there is no hemoptysis, no estrogen levels, no surgeries or trauma requiring hospitalization within the last 4 weeks, no prior venous thromboembolism, and no unilateral leg swelling. If none of these are present, you can rule out. So you're ruling out. You need not get any investigations done at all. This is known as PE rule out criteria. But if you top most differential diagnosis or second topmost differential diagnosis is a PE, then directly go ahead with the Wells score and get this Wells score done. Next one is coming is once you got in Wells score, how do you go about the investigations? As I told you, more than 4, then you're directly getting a CTPA. If positive, it's a diagnosis. If CTPA, that is CT pulmonary angio. If negative, then are you suspecting a DVT in this patient? Next question. If suspecting a DVT, then consider and getting an ultrasound scan done. If not suspecting, then think of something else. Here also, if Wells score is less than 4, you're just getting an equal or less than 4, you're just getting a D-dimer. If D-dimer is positive, get an CTPA. Negative, directly rule out. So it is quite simple here. Remember that if there is a delay in getting a CTPA, or if there is a delay in processing D-dimer, always give anticoagulation while you're waiting for it. Okay, ideally, CTPA or D-dimer should be, CTPA should be done immediately. D-dimer should be done, or the results should be available within 4 hours. If there is a delay happening, you're not able to get a CTPA done immediately, or D-dimer, you can't get the results within 4 hours, start them on anticoagulation. Okay, don't delay it, start them on anticoagulation. So what are the investigations required here? So you're getting a D-dimer. ECG is required. It might be in cardiac cause because it's a chest pain. CTPA as indicated. Echo is very important, especially in unstable patients. Tropi, again, if you're thinking of a cardiac cause, and tropi might be in a PE patient. If tropi is elevated, that means there is an significant RA-RV dilatation which is causing tropi elevation. These patients might require an thrombolysis, so you need to admit this patient. Coagulation profile, because you're thinking of thrombolysis. ECG, there is a classical finding what you can observe in this patient. Most common ECG finding in a PE is tachycardia. that is increased heart rate. Okay, very rarely seen. Around only 10 to 15% of the patients will get a classical pattern where you see S1, Q3, T3, we call it. Okay, so S wave is seen in lead 1, as you see here, as pointed here. Q wave is seen in lead 3, and T wave inversion is also seen in lead 3. So we usually call it as an Q3, T3, S1. That is, S wave is seen in lead 1, Q wave is seen in lead 3, T wave inversion is seen in lead 3. Okay, so this is a classical presentation of PE, but unfortunately, it's not seen in every patient who presents with PE. Most common finding they might ask you on the ECG is tachycardia. So how do we treat a DVT or unstable PE? How do we treat these patients? If they don't have any above mentioned things, then you're treating with direct oral anticoagulants, which is apixaban or rivaroxaban. If not suitable, then we'll be giving low molecular weight heparin along with warfarin. So low molecular weight heparin, you will continue at least for 5 days till the INR is 2 on 2 consecutive readings, then you will be stopping it. What if the patient has antiphospholipid syndrome? Then low molecular weight heparin plus warfarin is the preferred one. What if he has an active cancer? Apixaban or rivaroxaban is the preferred one. If not suitable, you can use only low molecular heparin or low molecular heparin with warfarin, or unfractured heparin plus warfarin can be used. What about renal impairment? Only in severe renal impairment we'll be using low molecular weight heparin or unfractured heparin. Otherwise, we end up using direct oral anticoagulants or low molecular weight heparin or low molecular weight with heparin. So you have a lot of plenty of options. Okay. Remember that if none of this are present, you are just giving apixaban or rivaroxaban, preferred mainly because route of administration, it can be given orally compared to low molecular weight heparin like enoxaparin. Commonly brand name is Clexane, you have to give it in subcutaneous form. So you need to get a prick done every day, usually twice daily you're giving. So 2 times he needs to get a prick done. He may not like it. That's why the oral are preferred over low molecular weight heparin. And it is given over a long time. So long time, how many days needs to be given? Not our headache, so we'll not discuss about it. So in a DVT, can you do a direct catheter-directed thrombolytic therapy? Yes. If the symptoms are less than 14 days and he has a good functional status, basically an young individual, life expectancy is more than 1 year, again, an young individual without any comorbidities, with low risk of bleeding, you can think of catheter-directed thrombolytic therapy directly. The question can ask you with an hemodynamically unstable PE. You're suspecting an hemodynamically unstable PE. Why? It's very rare that you have an CTPA already done and the patient is vitally unstable. Vitally unstable and you have an CTPA, it can't happen. Because if the patient presents to you to the ED and if he's hemodynamically unstable, then you will not shift him to the CT scan. So don't get an CT scan done. It is not advised to shift this patient out of the resuscitation. So what to do? If you're suspecting a DVT in this patient, just get a bedside Doppler done. That will nail the diagnosis. If the DVT is present, then this patient is most likely having a PE. Then you can go ahead and thrombolize this patient because hemodynamically unstable. Next thing is get an echo done. Echo, if the patient is hemodynamically unstable, it has to be a massive thrombus. If there is a massive thrombus, there will be pressure on right side of the heart. So you will see dilatation of RA and RV. Then on these parameters, if you're suspecting, directly go ahead with thrombolysis. Do not delay. Don't tell I'll stabilize this patient, I'll get a CTPA done. Once I have a report of CTPA, then I'll start on thrombolytics. No, this evidence are enough, indirect evidence are enough. You can go ahead with thrombolysis. If thrombolysis is contraindicated, for example, this patient has an intracranial bleed, or if the patient has a major surgery in the last week, you can't go ahead, then you can plan for surgical embolectomy or catheter-directed thrombolysis. Preferred one is surgical embolectomy. So what you're doing here, so you go, our interventional radiologist will insert a catheter to the culprit artery. For example, here the culprit artery, you can see here, So a catheter will be inserted. You'll go to this culprit artery and break it down, drill it and break it down. So mechanically, you are removing the clot. Preferred one where thrombolysis or contraindicated. All right. After thrombolysis, start them on unfractured heparin. Why not heparin? Why not give low molecular weight heparin here? Because this heparin acts much faster. There is an acute onset of time here compared to the others. They take time to act. What about if a venous thromboembolism presents in pregnancy? It is almost 10 times common in pregnancy. D-dimer is not recommended as per RCOG, that is Royal College of Obstetrics and Gynecology. Low molecular weight heparin should be studied on all the patients whom you suspect and DVT or a PV, that is venous thromboembolism. If you're suspecting, start them on low molecular weight heparin every patient till you rule them out or till you get an obvious diagnosis. If you're suspecting in DVT, it's easy, get in a duplex ultrasound, there is a Doppler ultrasound scan done because it's safe in pregnancy, you can get it done. What about PE? PE still, if you're suspecting in DVT and PE, get an Doppler scan done first here. Okay, why are you getting a Doppler scan done first here? Because if it's a DVT, you'll start on low molecular weight heparin that will treat the PE also. That's the reason you go ahead and get a Doppler scan done. That is a simple method and that is safe in pregnancy. So what if what if there is no signs of PE, no signs of DVT, but you're suspecting an PE? So no signs of DVT, so you're not getting a Doppler scan done. Then get a chest X-ray done to rule out if there is any other lung pathology which is causing these symptoms. Okay, don't get a CTPA done, do a chest X-ray first. Usually what you do is lead jacket is placed over the abdomen so that the fetus is protected. Then you will go ahead and get a chest X-ray done and the exposure is very minimal in a chest X-ray. Which one to prefer in a pregnant woman? You're suspecting in PE, there are known signs and symptoms of DVT. You can't go ahead with a Doppler scan. What to do? At this point of time, you will give the option to mom to select either VQ scan or an CTPA. It has its advantages and disadvantages. They can test you on what are the advantages and disadvantages. VQ scan carries an increased risk for childhood cancers. At the same time, it has decreased risk for maternal breast cancer. CTPA has an increased risk for maternal breast cancer, slightly low risk for childhood cancers. Okay, so this you need to explain to the mom and she will choose. You are not choosing, mom will be choosing. Treat with low molecular weight heparin should be commenced continuously until PA has been excluded, similar to DVT, what we discussed in the previous class. Low molecular weight heparin is preferred here. Don't ever give an warfarin. Heparin is also not preferred. Low molecular weight heparin is preferred here in pregnancy. If it's a massive PE, what to do? At this point of time, if there is a massive PE in this patient, you will not take a call. You will involve all the other specialties, involve the radiologist, involve the intensive care unit, involve the pulmonologist, let them all come and you sit together with them and come to a conclusion what needs to be done. Because thrombolysis in a pregnancy is quite difficult to manage. Okay, it can cause bleeding, fetus might be at risk. That's the reason thrombolizing in pregnancy is not recommended. If recommended, it should be a multidisciplinary team recommendation. So you're not taking a call here. So this completes venous thromboembolism. If anyone has any doubts, you can ask me. Just the last point before you ask me the doubts. If, for example, not a pregnancy I'm talking about, if a normal adult, male or female comes, you're suspecting both, please mute, you're suspecting both pulmonary emboli and DVT. So which scan, now the dilemma will be whether to get an CTPA done or whether to get an Doppler scan done of the limb. Get an CTPA done first. CTPA is preferred, or PE is more life-threatening than an DVT. So you will be getting a CTPA scan done directly than going ahead with a Doppler scan. So now you can ask me if you have any questions.
Sir, sorry to interrupt you. Sir, if all these things, as you said, CTPA can be done only when the patient is hemodynamically stable. If the patient is hemodynamically unstable, what next, sir?
That's when, as I explained you need to get an echo scan done. If you're suspecting a DVT also in that patient, get a Doppler scan done. Echo and Doppler will give you indirect indication along with an ECG to see whether to go ahead with a thrombolysis. So you're directly thrombolizing with the indirect evidence what you're getting from an echo and on an Doppler scan.
Okay, sir, fine.
Ramir, sorry, can you repeat the ECG changes in BE?
Sinus tachycardia is the most commonest ECG change what you will see in PE. Okay, the classical change what you see is in very small fraction of the patient you'll be seeing, that is S wave, QRS, S wave, that is a negative one here. This S wave is seen in lead 1. In lead 3, that's why we call it as in Q3. In lead 3, you're seeing Q wave, that is first negative deflection after an P wave, we call it as in Q wave, that is seen. And T wave inversion is also seen in lead 3, that is nothing but T3, we call it. In simple terms, we call it as in Q3, T3, S1 changes seen in an PE.
So I mean, is there a rule
So
for
the right
ABG?
bundle branch block
PE?
not classically appear.
One of you at a time, please.
In same point, ECG changes, right bundle branch block. I read in some sources there is right
the
bundle
findings,
branch
as I
block.
told you, tachycardia, incomplete right bundle branch block can be seen, and T wave inversions in inferior and anterior septal leads can be seen. Most common finding is tachycardia, what you see in PE. The most classical finding is S1, Q3, T3. Incomplete right bundle branch block, most of the time we might end up ignoring it because it's seen in normal adults, young adults also. Okay, as I mentioned here, these findings also can be seen in PE.
Good evening, sir. Can you explain the DVT chart, sir, when the score is more than 2, sir?
DVT, if the score is more than 4, you will directly go ahead. In DVT, you are talking about 2 or more. You're getting a Doppler scan done directly. Okay. If the Doppler scan is getting delayed more than 4 hours, start them on anticoagulants. Okay. If the Doppler scan is positive, it's a DVT, you'll treat it as a DVT. No issues with that. If it's a negative one, then you are getting a D-dimer done. Doesn't mean that you are ruled out DVT if the Doppler scan is negative. Okay, you're getting a D-dimer done now. If this D-dimer is positive, then you are asking the patient to come back after a week's time to repeat the scan. If the repeat scan is also negative, then you are ruled out.
Thank you, sir.
Dr. Amin, what is the preferred thrombolytic for massive BE?
You can, it depends on local protocols, but the preferred one is altiplase. The most common indication to go ahead with thrombolysis is systolic blood pressure less than 90. But we usually consider in any patient who is hemodynamically unstable to thrombolyze them.
You can do direct thrombolysis, catheter direct thrombolysis in pregnancy.
Again, it should be in multidisciplinary to see whether you can go ahead and do an intra-arterial thrombolysis or intravenous thrombolysis, or you're planning for an embolectomy, surgical embolectomy. So it will be an multidisciplinary. So unlikely they'll test you. If they are at all ask you, there will be an option of multidisciplinary team will take a call. So you'll involve in multidisciplinary team and take a call on that one. Because DIC can set in if you use thrombolysis in a fetal deaths are very common during thrombolysis. Fetus will be affected. Let's go.
The score, what is it, the minus 1.5? Do you need to subtract from the total, sir?
Where is minus 1.5? Well score for PE?
Yes.
There is no minus in well score for PE.
The previous one, sir.
That is DVT.
DVT, sorry.
DVT is minus 2 points if there is an alternative diagnosis which is as likely as DVT or more likely. So you're not thinking of DVT in this case. That itself will carry minus 2 points. So most likely DVT is not the diagnosis here. If you're telling means that is not a DVT, something else is going on, look for that. They mean by that.
Dr. Amin?
Yes, please.
In case of DVT, you told that within 4 hours we will do Doppler, or within 24 hours. If the patient come after 24 hours, then what we will do?
Again, it remains the same. After presentation to the emergency department, they are telling you what to be done. Okay, the time starts from emergency department. Once you see the patient, from then the time starts.
Okay, got it. Thank you.
Okay, let's go ahead with the infection. Pneumonia. Pneumonia we see very commonly in multiple patients. It can be a bacterial. Most common bacterial infection is strep pneumonia. It can be a viral, especially in UK. Viral pneumonias are more common. It might be caused by influenza A or B. Atypical pathogens can be seen, especially in immune compromised individuals, like mycoplasma pneumonia, chlamydial other bacteria also can cause. These are atypical pathogens. But in an immunocompromised individual, if you see an bilateral infiltrate extensively involving the lung fields, always think of pneumocystitis gyroway. You're thinking of an HIV patient. Okay, HIV patients are more prone for this infection where there's a bilateral infiltration on the chest. This is very important. They have asked multiple times. I think in last 3 days, every time they're asking the same question. Slight trick around, slight changes were there, but similar question. So how does a pneumonia patient present? A pneumonia patient, there is an infection, so there will be a fever. So there is an consolidation of the lungs. So there will be some amount of chest pain will be there. So there will be some pleuritic chest pain, there will be fever, and there will be cough. Usually cough will be having some sputum. Sputum will be yellowish in color. Okay, this is the classical presentation of a pneumonia. Everyone knows it. So what to do with this patient? When to admit or when to discharge this patient? That's where the Krupp score comes in, which is a mnemonic where C stands for confusion, U stands for urea. In millimoles, you need to remember more than 7. R stands for respiratory rate, more than or equal to 30. Blood pressure less than or equal to 90, or diastolic blood pressure less than or equal to 60. Age more than 65. Everything carries 1 point. Depending on that, we have classified into mild, moderate, severe. Mild, just oral antibiotics, discharge them with follow-up with the GP. Moderate, you need to take a call whether inpatient or outpatient, depending on the patient's comorbidities and living conditions, socioeconomic status. 3, always admit them. 4 or 5, admit in ICU. 3 in wards you are admitting, 4 or 5 you are admitting in an ITU or ICU setup. 2, inpatient or outpatient, you take a call. 0 or 1, outpatient, just an antibiotics. So always get in chest X-ray for the diagnosis. You need full blood count, urea, electrolytes, LFT, CRP are required as in routine to see how severe is the infection. Only moderate to severe cases. Mild, you're not collecting the cultures because you're discharging them on oral antibiotics. Moderate to severe, you might end up admitting them. That's where the IV antibiotics will be required. That's the reason you require to get blood cultures, sputum cultures. Sometimes you might require pneumococcal and Legionella urine antigen testing. Not always. From case to case, you need to see, and if required, if there is a breakthrough in the community where you're working, then you might have to go and get this antigen test done. Otherwise, it's not required always. If oxygen saturation is low, give oxygen first. If the patient is in septic shock because there's a source of infection, give IV fluids, give antibiotics. Think about if this is an elderly patient who is confused, might be immobile for long, whether he needs prophylaxis for venous thromboembolism. If required, if it is a severe on a Krupp score, it is a severe, involve the critical care team, see whether ITU admission is required. As I told you, pneumocystitis gyroway, always think of an HIV. Okay, as it is an HIV infection, leukocytes will be more. Okay, sorry, lymphocytes will be more. Leukocytes will be more in an bacterial infection. Okay, lymphocytes will be more in a viral infection. This is a virus. HIV is a virus with high lymphocytes counts, with bilateral infiltration, with some weight loss. You should always think this patient might be having HIV. That's why he is having bilateral infiltration. I know you guys might start thinking about it might be why not miliary tuberculosis or other diagnoses. Other diagnoses are very rare. Miliary tuberculosis, for you, if he is an Indian who is coming to an UK with a history of travel to India, then only think of tuberculosis. Otherwise, don't think of miliary tuberculosis and all. It's a very rare entity in the UK. Tuberculosis itself is very rarely seen. Treatment is trimethoprim sulfamethoxazole, also known as cotrimazole. It's one and trimethoprim sulfamethoxazole, also known as, I think if I'm not wrong, it's cotrimazole also is known as. Tuberculosis. Tuberculosis, whenever they give an classical X-ray. Okay, upper lobe consolidation with cavitatory lesion. A classical X-ray will come. None of you, I'm sure most of you are from either Southeast Asia, where they are tuberculosis. You see patients in and out. Shouldn't be any difficulty. Usually there will be a history of travel to India or Bangladesh. They love labeling India or Bangladesh as pandemic or endemic for tuberculosis. So there will be a travel history. They'll give this X-ray and they will ask you for the diagnosis. Usually they'll stop there for diagnosis. Unlikely they'll ask you on the treatment. Usually we treat with 4 different kinds of antibiotics. It is a multi-drug resistant bacteria. So 4 different kinds of antibiotics are required. This is usually given for only 2 months. This is given for 6 months. It's an extensive long treatment. Isoniazid, rifampicin, pyrazinamide, and ethambutol. Unlikely. They'll mainly concentrate on diagnosis. If you know the diagnosis, just refer to the admit them, isolate this patients. Okay, don't forget to isolate this patient. This patient needs to be isolated. Okay, tuberculosis can spread droplet infection, so you need to isolate this patient during admission. Very important, one question minimum, if not more than one, will appear in the examination on spontaneous pneumothorax. So we will break down this and know in and out about spontaneous pneumothorax so that you don't miss out in the examination. Pneumothorax, we know from our trauma classes, the presentation is quite similar. Chest pain will be there, pleuritic chest pain, it will be as described previously. There will be some amount of shortness of breath. There will be reduced air entry on the affected side. Okay, hyperresonance on percussion, one of the first signs to appear. Reduced expansion of the chest on the affected side. Okay, trachea deviated to the opposite side. Only in tension pneumothorax you see it, otherwise you don't see it in a normal spontaneous pneumothorax. So we are not discussing about tension pneumothorax here. This spontaneous pneumothorax is broadly divided into 2, primary and secondary. When do we call it as a primary pneumothorax? If there is no underlying lung disease. Simple, no underlying lung disease, primary pneumothorax. When do we call it as a secondary pneumothorax? There should be an underlying lung disease either on examination or in chest X-ray, or he should be a known case of some underlying disease like an asthma, COPD, interstitial lung disease, something is known to have an underlying lung disease. Or on examination, you feel that this patient is in COPD, or you get an X-ray and you have a classical finding of COPD. This patient has a tubular heart, there is a flattening of the flattening of the diaphragm, there is a barrel chest, then you're obviously thinking of an COPD this patient might be. Then you're thinking of secondary pneumothorax. Or he should have a significant history of smoking, plus don't forget this, both should be present. If he has only significant of the smoking history and he is only 25 years old, you're not bothered. It is not secondary pneumothorax, it's a primary pneumothorax. Here there is a significant smoking history, plus he is more than 50 years of age. This is a secondary pneumothorax. You need to know how to differentiate between primary pneumothorax and secondary pneumothorax, otherwise it becomes difficult in this algorithm. Before we go into this algorithm, few more things. When you're measuring the size of pneumothorax, you need to measure at the hilar region. This is the hilar region. You need to measure at this level. You're going horizontally, so you're measuring at this level. So here I'll be measuring at this level. So from chest wall to the parenchyma, what is the distance? From rib gauge to the chest to the rib gauge to the parenchyma, what's the distance you will be measuring? This is the measurement taken at the hilar region. Never measure at the apical region. This is more for USA related. This is according to BTS guidelines, what we follow in UK. Before we still enter into the algorithm, remember that if you go and study BTS guidelines is not just this algorithm. There are around 40 pages of guidelines on spontaneous pneumothorax, what needs to be done. If you go through it and read through it, when they mention breathlessness, they mean it isn't significant breathlessness. John, do you have breathlessness? Yeah, I'm feeling slight breathless. That means it's not breathless. He'll not be able to talk if he has significant breathless. Yeah, doctor, I'm having breathlessness. That means he is having significant breathlessness. He's not able to complete a sentence at all in a single breath. He's having a significant breathlessness. His saturations are low. He is having significant breathlessness. That is known as breathlessness when we use breathlessness here in this algorithm. Now let's break down and go through this algorithm, which is very important. A spontaneous pneumothorax, if it is a bilateral or hemodynamically unstable, directly go ahead and place an ICD. Don't bother going ahead and seeing whether it's a primary, secondary, need not. If it's a bilateral or hemodynamically unstable, directly ICD. That is just drain you're placing. This one we have discussed already. So if it's a primary pneumothorax, first thing you are saying was the size of the pneumothorax at the hilar level. If it is more than, remember that it's not equal to 2 centimeters, it's more than 2 centimeters, or the patient is significantly breathless, then you will aspirate. Okay. You will usually aspirate less than 2.5 liters. You shouldn't aspirate more than 2.5 liters. Aspiration should be less than 2.5 liters. Once you have aspirated as much as you can, then you see the size. If it's come down less than 2 centimeters, if the size is less than 2 centimeters, and or the breathing difficulty which he had come in with has resolved or has gotten better, then you can just ask him to follow up in an OPD with a chest physician after 2 to 4 weeks. What about in secondary pneumothorax? Remember that in secondary pneumothorax, you're admitting all the patients. You're not discharging any patients here. If the size is more than 2 centimeters, you're directly placing a chest drain. Or if it is significantly breathless, directly placing in chest drain. No, the size is not more than 2 centimeters. Is it between 1 and 2 centimeters? Yes, aspirated. After aspiration is less than 1 centimeter, you just admit them with high flow oxygen and observe for 24 hours. Or it is less than 1 centimeter at the initial time itself, then you are just admitting them with high flow oxygen and observe for 24 hours. Okay, here in primary pneumothorax, again, when do we get an ICD done? We get an ICD done if it's less than 2 centimeters, even after aspiration. Don't repeat the aspiration again and again. Even after an aspiration, only once you will be doing it. Still, it is more than 2 centimeters, then you will go ahead and place and chest drain. Remember that whenever you are admitting the patient, you are admitting this patient on high flow oxygen. Why do we admit this patient? Research has shown that pneumothorax, the patient who is on pneumothorax recovers much better if they are on high flow oxygen. That's why everyone gets an high flow oxygen inspired. Doesn't matter what their oxygen saturation levels are. Chest drain, preferred method of placing a chest drain is Seldingham's technique. It's a Seldingham's technique. What we use it is a technique, and usually it's an aid. So small size chest tube should be sufficient. For needle aspiration, we are telling a needle aspiration here, aspirate. Again, we are telling an aspirate here. We usually use around 16 to 18 gauge. And the site for pleural aspiration is second intercostal space, mid-clavicular line. From your trauma, we know other places. ICD remains the same for trauma and here. Needle decompression for adults changes. It's fifth intercostal space, slightly anterior to the mid-axillary line. That's why I have put up here. In children's, needle decompression is again second intercostal space, mid-clavicular line. So pleural aspiration, both in adults and in child, according to BTS guidelines, it's second intercostal space, mid-clavicular line. Don't forget. What about discharge and follow-up in this patient? So when do you discharge or when do you follow up these patients? Patient should be advised to return to the hospital if increasing breathlessness is there. So basically, if he gets worsened, get back to the hospital. Okay. He needs to follow up with respiratory physicians. Usually after 2 to 4 weeks, you would have given the appointment to follow up. And you should continue following up with the respiratory physician till there is complete resolution. These are the two important points here. You should tell them till complete resolution is there, you shouldn't travel, air travel. So you shouldn't take any flights and travel around till there is complete resolution. For your lifetime, you have been banned for diving. You can't go for deep sea diving or you can't go for swimming. If at all, if you have to go, you want to go because that's your profession. You are a professional diver, you do in deep sea diving, you are a coach of in deep sea diving. So you need to go back, then you need to undergo an bilateral surgical pleurectomy. And lung function test should come back to the normal, and CT scan post-operatively should be normal. So all these criteria needs to be met if you have to go for diving. So from emergency point of view, no diving for you. Don't travel it till the respiratory fibrillation stage there is complete resolution of your pneumothorax. Then only you travel. Otherwise, don't travel at all. Okay. Any questions till here? You can ask me.
Excuse me, sir.
Yes,
In
please.
secondary pneumothorax, even the size, patient have complaining breathless, directly go for chest drain.
Yes.
Even the size.
Breathlessness should be significant breathlessness. Remember, it is always significant breathlessness.
Okay.
Directly, you will go for chest drain incision.
Chest drain. Okay.
So can you just explain me in spontaneous pneumothorax at hilar region measurement is there, no? That one.
This region is known as hilar. So we are going exactly here and we are measuring here. Usually in US, they'll measure here, that is known as apical. So from here to here, usually apical will be more than the hilar. Sometimes in the exam, especially not in MRChem, in FRChem, they can confuse you. They'll give you only the apical reading. So they'll tell apical reading is 2 centimeters. Then you can assume that if apical is 2 centimeters, this will be less than 2 centimeters of the hilar region. Then you can go according to the algorithm and treat it. Okay, that's in trick what they use it in FRChem exam, unlikely to use it in MRChem exam. So this is hilar region. So at that level, you are measuring it.
Sure, thank you.
Sir, is there a difference between the aspiration, pleural aspiration and needle decompression, or just the site?
There is lots of difference between aspiration. You're aspirating it. In decompression, you're not aspirating it. You're just putting a needle there. Once the gush of air comes out, you will close the tap of the needle. That is needle decompression. You're decompressing. You do it decompression when there is a tension pneumothorax. There is a tension, so you're decompressing the tension. Aspirating, you will connect a needle, then you are connecting in 3-way, then you are connecting in large cc syringe, usually a 50 cc syringe, then you are aspirating and you are draining, aspirating the air. So there is a lot of difference between both.
Yes, thank you.
Usually people get confused. That's the reason I put together here. Coming to hemoptysis. Hemoptysis is nothing but coughing of the blood. It can be mixed with the sputum, it can be mixed with the saliva. So coughing of the blood. Because coughing of the blood, it doesn't mean that there is one thing. There are lots of differential diagnoses. It might be inflammation like tracheobronchitis or chronic bronchitis. It might be an infection. It might be infraction. It might be an abscess. It can be a trauma. It can be a cardiac cause. Like in PE, we said hemoptysis might be present. Left ventricular failure, usually pink frothy sputum, what we describe it. So it can be present. If there is an abnormal fistula, also can present. Some vascular diseases, vasculitis, like SLE, Wegener's disease, Good-Poster syndrome also can present with hemoptysis. It is very difficult to pinpoint and say which one is causing hemoptysis unless we have other symptoms and other parameters to really diagnose it. So it will become easy if you have other symptoms to know whether it's because of PE, this patient is having hemoptysis, or it's because of a pneumonia, this patient is having hemoptysis, or because of cancer he's having. But how do you manage a massive hemoptysis? First, let's see what is massive hemoptysis. If he has coughed up more than 400 ml in last 3 hours, or he's coughed up more than 600 ml in last 24 hours, then we call it as a massive hemoptysis. What is the management we are saying now? Start them on high flow oxygen, everyone. Place the bleeding lung dependent side. For example, if the bleeding is from the left lung, place them on the left lateral position so that the pooling of the blood occurs in the left lung itself and clot can form because of the tampon effect. Do an bronchoscopy and find out where the bleeding is from and try to cauterize it if it's possible. Most of the time, and recent advances, recommendation is used to embolization of the bronchial artery under radiographic control. Basically, embolization by an interventional radiologist. Radiation therapy may be helpful if there is a cavitatory lesion. especially, and cancer, which is causing cavitary, radiation can be helpful in this situation. What they'll test you, every patient needs to be put on high flow oxygen. Bleeding lung needs to be on the dependent side. So the lateral side, if you're suspecting on the left side or right side. But again, it's difficult unless you got a CT scan done to see where is the bleeding. So CT scan will suggest on that side, you'll keep him lateral position, and you'll involve the interventional radiologist and just physician. They will take a call whether to do an bronchoscopy or to do an embolization. Sometimes you're in ED, you might get false reading on pulse oximetry. Why? Because of dark skin, severely shocked. If the blood pressure is less than 90, the probe will not read appropriately. False nails. In UK, they like to keep false nails, especially if the nails are polished with black, blue, or green color. It can interfere with the pulse oximetry reading. Hyperlipidemia and propofol infusion can interfere with pulse oximetry reading. Carboxyhemoglobin, methemoglobinemia can give false high readings. Intravenous dyes like methylene blue given in hemoglobinemia. Venous pulsations can, for example, obstructed venous returns or tourniquet constrictions can give false readings. Okay, not very important. You just need to remember there are a few conditions which can give a false reading. This is again very important. This is important from practical purpose, and this is important from exam purpose also. If you're practicing in emergency department, if you don't know how to read an ABG, first learn that, then start practicing what I usually tell my juniors. How to read an ABG. Arterial blood gas, you have it in your hand. First thing you need to see is pH. If pH is low or pH is high. If pH is low, then it is acidemia. Acidosis is there. Once acidosis is there, next thing you're seeing is the PCO2. If PCO2 is high, then you know it's respiratory acidosis. If PCO2 is not high, the next thing you are seeing is bicarbonate. Is the bicarbonate low? If the bicarbonate is low, then it is metabolic acidosis. So we know if pH is low, is it acidosis? How to know whether it's respiratory or metabolic? If high PCO2 is there, it's respiratory acidosis. If low bicarb is there, then it is metabolic acidosis. Okay. If both are present, high PCO2 and low bicarb, then it is a mixed respiratory and metabolic acidosis, we call it. I'll come back to the compensation. If pH is high, then the patient is having alkalosis or alkalemia. Alkalosis, then you are again seeing PCO2 first. If it is low, then it is respiratory alkalosis. Then go and see whether bicarb is high. If bicarb is high, then it is metabolic alkalosis. If both are present, then it is a mixed respiratory and metabolic alkalosis. What is compensation? Body wants to maintain this pH in a range of 7.35 to 7.45 because body biochemistry, the mechanism of body doesn't work well if the pH changes. It wants to maintain at any cost at a particular range that is 7.35 to 7.45. So it will start compensating it. What is metabolic alkalosis? So for example, in this patient who is having respiratory acidosis, what will body do is kidney will start retaining bicarb. By retaining bicarb, it tries to push the pH towards the normal side. So if you see high bicarb along with respiratory acidosis, then we call it there is a compensation. Usually this compensation is incomplete compensation. Why we call it as an incomplete compensation? For a complete compensation, the pH value should go to normal. If there is no complete compensation, then we call it as an incomplete compensation. Usually, if not always, it is incomplete compensation. In metabolic acidosis, you start breathing fast so that there is carbon dioxide washout. So you wash out. So you'll be seeing low levels of PCO2 here, low levels of PCO2. In respiratory alkalosis, what you will do here? Kidneys will try to excrete more bicarbs. So less bicarbs will be seen. Then again, we call it as in compensation. Usually it's an incomplete compensation because pH is not coming back to the normal. In respiratory acidosis, there is high PCO2 levels along with metabolic alkalosis. Then we call it as an incomplete compensation. That means, how do you call it? Metabolic alkalosis with incomplete respiratory compensation. or metabolic acidosis with incomplete respiratory compensation. Body is trying to compensate. This is known as compensation. These are the normal values. What you need to remember, don't depend on to be given in the question. You need to remember in kilopascals itself, millimoles, and this one you need to remember. It should be back of your hand. You shouldn't refer anything. You should be able to remember this easily. This is more FRChem related. If anyone is interested, can stay back. I will explain them. For MRChem, it is not required. Anionic gap. Anionic gap is nothing but cations minus anions. That is sodium plus potassium minus chloride and bicarb. Usually it is less than 18. Normally it is less than 18. So either it should be high or in normal range. Okay, there are only two chances. It can be low anionic gap. So why is anionic gap important? If there is a metabolic acidosis on ABG, then you need to see an anionic gap. If you know the anionic gap is raised, then you have certain causes. If it is normal, you have certain causes. So you can narrow down your differential diagnosis depending on the ABG and anionic gap. That's why it is important to see in sick patients. This one you can remember with a mnemonic known as mud piles, where M stands for methanol, U stands for urea, D stands for DKA, P stands for parahaldehyde, I stands for iron, L stands for lactic acidosis, E stands for ethanol, S stands for salicylates. Mud pipes is easy to remember. Normal metabolic acidosis, normal anionic gap, mainly see in diarrhea. Type 2 RTA, that is renal tubular acidosis. Addison's disease, when you're using carbonic anhydrous, hypoaldosteronism is nothing but Addison's disease, also known as type 4 renal tubular acidosis. Extra chlorides, for example, ingestion of ammonium chloride or magnesium chloride. So mainly remember here diarrhea, Addison's disease, carbonic anhydrous inhibitors, or can cause metabolic acidosis with normal anionic gap. Metabolic alkalosis, mainly seen in vomiting, because you're vomiting out the acid which is there in the abdomen, or NG tube suction, you're suctioning out the acid which is there in the abdomen. Conn's disease is exactly opposite of the Addison's disease. So what if Addison's disease, you're seeing metabolic acidosis, you'll be seeing metabolic alkalosis here. Conn's is opposite. Hypokalemia can cause metabolic alkalosis, because we know inside the cell potassium are more, outside it is less. So it is still less. So potassium is going out. So one positive is going out, something needs to go in. So hydrogen ion goes in, that leads to alkalosis, that is metabolic alkalosis. Massive transfusions because of presence of citrate can cause metabolic alkalosis. Respiratory acidosis, mainly depression. Respiratory depression is happening here. It might be because of a lung disease or CNS depression like an opioid, or neuromuscular disorders like an GB syndrome, or an airway obstruction, for example, foreign body aspiration. Respiratory alkalosis, most of the time it is physiological, for example, high altitude, anxiety, fever, pregnancy. But sometimes it might be pathological, as seen in salicylate toxicity. Okay, or it can be hyperventilation because of hyperthyroid, liver failure, carbon monoxide poisoning. You can see respiratory alkalosis. Most important pathological cause you need to remember is salicylate. Rest of them are more physiological, like anxiety, high altitude, fever, and pregnancy. You need to remember in that way. Okay. Anyone has any questions still here can ask me before we go to next part.
Doctor, can you please explain how we differentiate between acute and chronic respiratory acidosis, please?
Respiratory acidosis, that means there is respiratory acidosis. So pH is low, so we know acidosis. So you know carbon dioxide retention is there. Your question is how to differentiate between an acute compensation and chronic, or acute and chronic respiratory acidosis.
Yes, sir.
Kidneys, acute versus chronic, you're asking. So basically in kidneys are the one which are compensating here. Kidneys don't act immediately. It requires time for the kidneys to act. Let's take an example of COPD. In COPD, usually we see patients to have carbon dioxide retention, but their pH will be normal range. What has happened over the time, over like few days or few months, kidneys have thrown out enough bicarb so that it has completely compensated. So it is nothing but chronic compensation what has happened. Okay, and usually pH will be normal here. PCO2 will be high, but pH will be normal and bicarb levels will be low. This picture, if you're seeing, it is a chronic thing what has happened. What happens in acute thing? In acute thing, what you need to remember is it will never cause a complete compensation acutely. Kidneys can't act immediately. You know, urine is not formed immediately. It takes time for the urine to form. Okay. So usually you don't see metabolic alkalosis at all in an acute stage. If someone comes with an acute pH is 7.1, bicarb is, PaCO2 is 10 millimoles, then we are thinking of respiratory acidosis, but bicarb levels might be slightly on, slightly on the lower side, but will not be drastically low, and the pH will never be compensated. That is acute.
Thank you so much.
Sir, can you please explain complete compensation and incomplete compensation?
PCO2 should be high, right? For acute compensation.
For complete compensation, pH should come back to normal range, should come back to this normal range. Otherwise, we don't call it as an complete compensation. It will remain as an incomplete compensation if the pH doesn't come to normal.
Sir, in COPD,
yes, please.
In
For the
COPD, sorry, continue.
Sorry, can I speak?
Yes, go ahead.
For the acute COPD, for acute to say it as acute, the PCO2 level should be high, isn't it?
pH should be low. Mainly you're looking for pH, because in a chronic COPD patient, there will be chronic carbon dioxide retention.
Okay.
Okay, pH should be low along with PCO2 high. Both things should be present to call it as an acute carbon dioxide retention is there. Carbon dioxide is nothing but acid. Bicarb is nothing but is an alkali. Carbon dioxide, carbonic acid basically gets converted into carbonic acid. Acutely, if it is retained, the pH will fall down.
Okay.
Any more questions?
Sir, in end-stage renal disease, body will compensate.
Sorry, can you repeat your question? You're echoing.
An end-stage renal disease. So body will compensate.
Unlikely body will compensate. He will have a metabolic acidosis because of CKD itself. Body will not compensate. If kidneys are not working, compensation will not work. And that's where you need to see whether what is happening, respiratory compensation, you go further and see whether this compensation. I have told you what is mixed alkalosis, mixed acidosis. Can there be an respiratory acidosis with an respiratory acidosis with a metabolic alkalosis? Yes, that is also a possibility. Okay, for that you need to know this parameters which we have not discussed because it becomes complicated. Usually it is at the FRCAM level they want you to know. Okay, at the MRCAM level they test it till here. So let's go ahead and talk about few more conditions. Okay, might not appear, might not important. That's why we're discussing very briefly. Low-grade syndrome is a part of sarcoidosis. Usually it has a triad hilar lymphadenopathy. That is here what you can see, hilar lymphadenopathy. Acute polyarthritis. Usually ankle joints will be inflamed and they'll be painful. And they will be having erythema nodosum. They are nothing but skin lesions seen on the shins. Asbestosis usually gets exposed in a ship worker, miners, or pipe fitters. It is, if they are work for multiple years, they might end up having an ILD, that is interstitial lung disease. and they can be predisposed to mesothelioma. It is nothing but an carcinoma or an cancer of pleura. Okay. What is Pancoast tumor? Pancoast tumor is an apical tumor. So you can see here, it's a lung tumor, apical tumor. Close to it is the sympathetic nervous system and recurrent nerve which runs. Compression of the recurrent nerve will cause hoarseness of voice. Compression of the sympathetic nerve, sympathetic chain here will result in Horner's syndrome. What is Horner's syndrome? Horner's syndrome is an triad, what you're seeing. Three things are seen in Horner's syndrome. There is an small pupil, meiosis. Eyelids are partially closed, known as ptosis, and there is no sweating on the ipsilateral side of the face, that is known as anhidrosis. This altogether known as Horner's syndrome can be caused because of Pancoast tumor. Pancoast tumor is an apical lesion. Okay, apical lesion that is nothing but a cancer of the apical, which involves the apical part of the lungs. Pleural effusion. We are not bothered about the pleural effusion till the patient is symptomatic. If the patient is symptomatic, then only we will think of aspirating or putting a drain here. Otherwise, we will not aspirate or not put a drain here, not our headache. We'll just admit under the internal medicine physician, they can manage it. Or if it's completely stable, we'll just tell the GP to follow up and let them refer to the chest physician. We are not taking any head. If the patient has significant pulmonary, that means he's breathless, saturations are low, his tachycardic, blood pressure is low, you're thinking this is because of pleural effusion, go ahead and aspirate it so that he's symptomatically better and send this fluid for investigation. They might ask you how to differentiate between transudate and exudate. According to me, they shouldn't ask you because you are not an internal medicine doctor to really break your head. You'll just aspirate, send for the investigations and admit this patient. But they might ask you on this lights criteria. That's why we have put it up. Always remember it's pleura which comes first, pleural fluid what you aspirated, then you're measuring or then you're comparing with the serum. Pleura is first divided by serum. It's always pleura above divided by serum. If the ratio is less than 0.5 of proteins, LDH is less than 0.6. If the pleural LDH is less than 2/3 of the upper limit, then you're thinking of transudates. Usually transudates are bilateral. It is caused by heart failure, liver failure, or kidney failure, mainly the nephrotic syndrome. Exudates, exactly opposite findings you are having. Mainly thing you need to remember, it might be because of infection, carcinoma, tuberculosis. Sometimes pancreatitis also can cause. These are the 4 important differential diagnosis for an exudate you need to remember. What is ARDS? This is very important. Okay. They want you to know what is ARDS so that you don't label everyone as an ARDS who comes to the emergency department. Severe infection is ARDS? No. There is a criteria to call a patient an ARDS. What is ARDS? Is it an acute respiratory distress syndrome? Okay. So these symptoms should be acute. Acute in the sense it should be within a week's time, acute within a week's time of the insult, or it is got worsened within a week's time. On an X-ray, it should be bilateral. That is on any imaging, CT scan on an X-ray, there should be bilateral opacities. Opacities in the sense wide. You can see both the lungs are washed out. This is also washed out. Along with that, ratio of PaO2. PaO2, you are getting it from an ABG. FiO2 is the fraction of inspired oxygen you are giving to this patient. While on a PEEP, usually if not on any ventilator, we'll consider PEEP as 5. If he's on ventilator, then you need to set the PEEP as 5. This should be the ratio that should be less than or equal to 300. Along with it, it shouldn't be able to be explained by fluid overload stage. For example, cardiac failure can present like this, or the image can look like this. Cardiac failure can look like this. It shouldn't be a cause of a cardiac failure or any volume overstate. For example, a CKD patient can have a volume overload state and can present like this. That shouldn't be, or it shouldn't be fully explained by that. Then only we call it as an ARDS. There is 3 classification: mild. Recently, they have changed mild into acute lung injury. This is the ratio what we spoke here. Depending on the ratio, they are classified into mild, moderate, severe, or acute lung injury, moderate, severe. Between 201 to 300, it's mild. Between 101 to 200 is moderate. Less than 100 or equal to 100 is severe. Okay, this is ARDS. How do we manage this ARDS? We basically give antibiotics and admit them. ARDS management is mainly ventilator settings. Lung protective ventilation you need to do. And again, you are not an intensivist, so questions will not come. This is not an anesthetic or an intensivist doctor's exam. It's more of an emergency medicine exam. They just want you to know the ARDS definition and classification. So any questions you can ask me before we go into recall questions. Let's go ahead into recall questions now. We have a 49-year-old gentleman who has recently traveled to India, has presented with a cough with expectorations last 2 to 3 weeks, high grade of fever. What's the most likely diagnosis?
Tuberculosis.
So if they are asking about tuberculosis, it will be very straightforward. Travel history will be there. Long history of cough of 2 to 3 weeks will be there. A very classical X-ray will be given. So this shouldn't be a problem. So we are going into the next question here. So basically a 60-year-old male, a known case of ISD and DM complaints of shortness of breath. PA confirms massive PE. He's immunologically unstable. He has a past history of stroke 2 months ago and was thrombolized. So what will be the best step for him or best management plan for him?
Thrombolysis.
Ideally, you would have done thrombolysis if last part was not there, because it isn't contraindicated. He had a stroke 2 months ago and thrombolized. So we are not doing and thrombolysis. So this it's not able to do an intra-arterial thrombolysis also. So the right answer would be radiological embolectomy is the right answer. So here in this question, they are asking well scope.
If there was in hello.
Yes, please.
If there was a question with no history of stroke prior, so you would have gone for thrombolysis?
Yeah, go ahead with the thrombolysis.
Okay.
If the patient is hemodynamically unstable, then wait for thrombolysis.
Cannot repeat thrombolysis for how long?
Usually after thrombolysis, 12 weeks. Major surgery, thrombolysis, 12 weeks, what you're looking for, that is 3 months.
3 months at least.
3 months we are looking out for.
Okay.
Can't hear you. Okay, we'll go with the next question here. We have a 33-year-old woman who is admitted with sudden onset of shortness of breath while shopping in the market, and there is no symptom, but had a laparotomy and removal of an uterus 3 weeks back ago. She has no past medical history and she's not a smoker. Otherwise, she was in respiratory rate of 26. Saturations are normal. Heart rate is fine. On examination, chest is clear. Heart examination is fine. CVS examination fine. There is no swelling or tenderness in her lower legs. What is the corrected well score?
4.5.
0.5. PE is the likely diagnosis. With the history what we are getting, it is a classical history what you are getting. So this itself gets 3 points. Previous surgery will give you 1.5. So total is 4.5. So the answer here is D. We have a pregnant lady complains of shortness of breath 2 days ago, associated with chest pain, which is worse on deep inspiration. There is CTPA done, shows and PE. What is the choice of treatment in this patient?
Molecular
weight
Low molecular weight heparin.
Low molecular weight heparin is the preferred one. Okay. Remember that we usually do thrombolysis if the systolic blood pressure is less than 90. Otherwise, we tend to give anticoagulants and try to manage with the anticoagulants.
Sir, why not heparin here?
Pregnancy.
No, pregnancy also we can give heparin, but according to the research and all, low molecular weight heparin acts better. And the thing is, heparin multiple doses needs to be given.
Okay. Heparin acts rapidly. That's what we were
Acts
discussing.
rapidly, but needs multiple doses needs to be given. Usually, either it should be a TID or it should be on infusion. This you can give it twice daily or once daily, and it can be given subcutaneous. That's the main reason the kind of RCOG I have recommended to go ahead with low molecular weight heparin.
Oh, okay.
A 25 years old female comes to the emergency department with complaints of fluidic chest pain, left-sided, no comorbidities, smokes 2 to 3 cigarettes per day, chest X-ray shows left-sided pneumothorax, measuring about 2.2 centimeters. Next best step. When they don't mention where they are measured, always assume that they are measured at hilar region.
Aspiration. Aspirate.
So, is it an primary or
less than
secondary?
2 centimeters.
This is a primary.
It's an primary. Though she is a smoker, it is an primary because she's only 20 years old. So we'll go ahead and we'll aspirate because it is more than 2 centimeters in size. We have a 45 years old chronic smoker's complaint of shortness of breath since last 2 to 3 days. Saturations on room air is 89%. X-ray shows pneumothorax. Measurement at the hilar region is 2.5 centimeters. Apex is 4 centimeters. Next best step.
Chest drain.
No.
Aspirate. Admit.
Primary.
Is this a primary or secondary?
Primary.
Primary always aspirate first. If it is more than 2
Sir, why can't it be
centimeters,
secondary? Because he's a chronic smoker.
age.
Should be chronic age more than 50 years.
Age more than 50 needs to be with chronic smoker. Both should be present. If, for example, if this patient was 55 years old, I would have directly gone ahead and put in chest drain because it would have become a secondary pneumothorax. Okay. So age, you need to carefully see age, smoker, then you need to see significant breathlessness, whether he is complaining or not.
Doctor,
Yes.
that means primary aspiration. Secondary, chest drain.
Secondary, if it's again, you need to go through the algorithm. It's not so simple. If the secondary, if the size is between 1 to 2 centimeters, then you will aspirate. In secondary, if the size is more than 2 centimeters, then you will place an ICD directly. So depends on that. We have an elderly male presented to the ED with complaints.
Sir, if it is, sorry. If it is secondary pneumothorax and the size is 1 centimeter, then
you need to go according to the algorithm. So you can't skip the algorithm. What's shown in the algorithm, you need to strictly follow this algorithm. Okay. If it's 1 centimeter, that is size is between 1 centimeter, then you're going and aspirating it in secondary pneumothorax. If its aspiration is successful, it has come back less than 1 centimeter now it is, then you will be admitting with high flow oxygen. If it still remains more than 1 centimeter, then you go ahead and place an ICD. So you can't forget, this is very, very important. Definitely one question will appear from the examination. You should be thorough with this algorithm. We have a 78 years old male presented to the ED with complaints of swelling of the entire lower limb associated with pain. 3 days back, he has undergone a hip replacement surgery. He was previously diagnosed with lower limb DVT, for which he was on warfarin for 6 months. Well score. So DVT well score they are asking about here.
3.
4.
Entire lower limb swelling 1. Previous surgery 1. Previous DVT 1. So it will be 3. Okay. We have a COPD patient who is in type 2 respiratory failure. Hence, NIV has been started with initial setting of EPAP of 3, IPAP of 15. Repeat ABG after 1 hour is following. What changes you will be doing on NIV? This we have studied in last class. Because it is COPD, we have put it up here. D is the right answer. For O2, you can just increase FiO2. For PCO2, we will increase IPAP. They're not mentioned about respiratory rate itself, so we're not making our head on respiratory rate. They're not given at all. Here, they're just asking maximum.
Yes, sir. Will increasing the IPAP will wash out the CO2?
Will help to wash out carbon dioxide. So difference you're seeing between IPAP and EPAP. IPAP needs to be constant. Okay, it needs to remain the same. EPAP should remain the same. IPAP you should keep on increasing. So the difference will be more. If the pressure difference will be more, the more carbon dioxide will be washed out. So only IPAP will be increased, not both IPAP and EPAP. Both IPAP and EPAP, if you increase, usually it will help to increase the PaO2 levels. Oxygenation will be better.
Okay, sir. Thanks.
Here they are just asking what is the maximum IPAP you can increase before the ITU review, or what is the maximum IPAP as an emergency physician you can
30.
30 again from last class algorithm. We have a long thing individual presented to the ED with complaints of mild pleuritic chest pain, left-sided. On further questioning says and has mild breathing difficulty also. Chest X-ray shows left-sided pneumothorax measuring about 1.2 centimeters. What will be the best step for him?
Discharge.
Discharge. What is the most likely cause for the pneumothorax here? Is it primary pneumothorax? Don't confuse.
Tall
Marfan syndrome.
Marfan
syndrome.
Okay. Usually primary pneumothorax, there will be some underlying connective tissue disorders like Marfan syndrome or Ehlers-Danlos syndrome that usually triggers them to have this pneumothorax. It's not that they're completely normal individuals. You see these primary pneumothorax individuals, they'll be abnormally tall and abnormally thin, suggestive of underlying some Marfan syndrome or suggestive of something else is going on. I just put up so that you don't forget your old classes. We have in shortness of breath here 1 week back, gradually worsened, history of wrist fracture a month ago. So what it will be?
Diaphragmatic rupture.
A month back, yes, did rib fractures means there was an injury to the chest. Might be there was an injury for the diaphragm also. It's small, it was, and now it might have enlarged and it has bowels have herniated here. So it is a diaphragmatic rupture, trauma case. Elderly patient presents to the ED with shortness of breath and cough. She has significant history of COPD. After 1 hour of medical treatment, ABG shows the following. What is the indication to start NIV?
PCO2 8.8.
High PCO2.
High PCO2. Sorry, the pH was.
pH.
There are 2 right answers here.
pH 7.35.
More than 6.5, more than 23. Respiratory rate, PaCO2, and pH. So there are 2 right answers here.
Option B. Sir, how the single best answer? Which one we should choose?
Most likely, if I'm not wrong, the pH what was given was pH was 7.1, not 7.2. Then which one will become the right answer?
pH.
CO2.
PaCO2.
This pH was actually 7.2 if I'm not wrong. Okay. PCO2, pH 7. PCO2. pH anything less than 7.15 is an relative contraindication. Okay. So remember that. So the right answer here is PCO2 of 8.8. If at all both are correct, they will remove that question from the examination. Don't worry. If the pH was 7.2 itself, both the answers are correct, they would have removed the question from the examination. So we have a 90-year-old female with history of asthma present to the emergency department with increasing shortness of breath and fits. She has been using increased amount of salbutamol inhalers for the last few days. On examination, respiratory rate is 35 and heart rate is 130, saturation is 91. She's unable to talk in full sentences. She has a widespread risk throughout her chest on auscultation and these other vital parameters, ABG parameters, what they have given. So how severe? They're just asking the grading here. How severe is it?
Is Q2 less than 92?
Acute severe asthma.
CO2 is in normal range, so I'm not worried. Saturation is 91. It is less than 92%. It is a life-threatening asthma.
Cannot complete them.
It's life-threatening. PCO2 normal, yes.
If PCO2 was, for example, 7, then you would have gone for near fatal asthma. Okay, so only one. If you see, rest of the things is not much suggestive of life-threatening. It's all suggestive of a severe asthma, acute severe asthma. Just one reading has changed your classification to life-threatening asthma, severity to life-threatening asthma, because saturation levels are less than 92. Again, we are having an well score here. Okay, well score, they are asking you to calculate here. So we have a 33 years old woman who was admitted with a sudden onset of breath in the supermarket. She has symptoms after laparotomy. This is kind of a repeat question, if I'm not wrong. 4.5.
Yes, repeat. It's 4.5.
Yeah, it is a repeat question, so we are not discussing. It's 4.5 itself, the answer here. Okay. This is an interesting question. Many people got it wrong. This was last but one diet. Acute onset of breathlessness while shopping, came to the ED in ambulance. Patient has undergone appendectomy 2 weeks back. Heart rate is high, blood pressure is low. Systolic blood pressure is less than 90. You're thinking of thrombolizing this patient. Saturations are low. What is the next best step here?
2D echo.
Dynamically unstable. I think altiplate thrombolysis.
Echo. دائما.
This is an
unstable patient.
Unstable patient, 2 diagnoses you can get it done. If you are suspecting DVT, get an Doppler scan done. Okay, if you're not suspecting a DVT, get an echo done to see whether there is right atrial and right ventricular dilatation. If this is such a massive thrombus to cause an hemodynamic instability, definitely there will be RA and RV dilatation on echo. That will give you an indirect evidence of an PE, and you can go ahead and thrombolize. Don't directly thrombolize. Many people ended up directly thrombolizing, further they didn't get the mark.
But sir, patient is unstable, 80/60.
Yeah, you're getting a bedside echo done, so you're not shifting for CTPA.
Altiplate is not first choice.
Once you get an indirect evidence on 2D echo or on Doppler scan, then you will go ahead with altiplase. That is, you will go ahead with thrombolysis. Here only you're suspecting, you don't have any evidence, you don't have anything to say that there's a DVT. You should have something to say it might be an DVT. Sorry, it might be an PE. So we'll go for the next question here. 22 years old man presents with the shortness of breath and pleuritic chest pain. He's not breathless and feels otherwise well. He has no past medical history and he's a non-smoker. The observation shows a respiratory rate of 18, saturation of 97%, heart rate of 72%. Blood pressure is in the normal range, temperature is normal. His chest X-ray confirms a small right apical pneumothorax, which is 2 centimeters. What is the most appropriate further management step?
Discharge and follow-up.
Discharge and follow-up.
Why not aspirate?
No
Because
complaint, no sign of asymptomatic patient.
Apical pneumothorax. Not more than 2 centimeters.
Yeah.
And asymptomatic.
It should be more than 2 centimeters to even consider. Again, it is an apical. Apical is 2 centimeters, means hilar will be less than apical for sure. So it is less than 2 centimeters. So you can just discharge this patient. We have a COPD patient with an ABG was done. This is the ABG what is given. What is your interpretation? Again, this is last diet question. Many got it wrong here. So it is not a type 1 respiratory failure. It's not a mixed.
Respiratory asymptomatic with partial compensation.
Partial metabolic compensation.
Sorry, this is an easy one. We have an pH loop, so we are thinking of acidosis. And by PCO2 levels are high, so it is a respiratory acidosis. Bicarb is on the higher level, so there is a partial compensation. So this is an easier one. This they didn't got it wrong. This is one more question which is coming up in a few slides. So we'll go for the next one. A young patient came with a pneumothorax of 3 centimeters, complaints of breathing. What's the most appropriate step here? Easy one, needle aspiration. They don't mention the site. It's an hilar region. When they don't mention the site, it's always an hilar region. From here is the last diet questions what we are discussing. We have an HIV, not from here, sorry, I'll let you know. HIV positive patient presents with cough and fever since last 3 to 4 days. X-ray shown below. COVID CPR, PCR, sorry, is negative. Treatment for this patient. What you're thinking here, diagnosis?
Pneumocystic cerevisiae.
Yes, exactly. That should be your diagnosis whenever you see that kind of X-ray. Young chap complains of shortness of breath and chest pain. CTPA done, diagnosed as in PE. Patient has no comorbidities. The following risk factors are given. What is the next patient? Everything seems to be okay. Slight tachycardia is there. What you will start this patient on?
Molecular weight heparin.
If everything, this patient is no comorbidities, nothing is there, then direct oral anticoagulants like apixaban or rivaroxaban should be given. Okay, you need to remember what we are talking.
Why not BE orally?
Sorry?
Why not the molecular weight heparin?
Yeah,
It's
why oral?
according to the recommendations. If you see the recommendations, if you go ahead and see the recommendations, what we have put up here, according to BTS guidelines, what they have recommended, you need to treat. If you see here, none of the first line of drug is apixaban or rivaroxaban. If any contraindications are there, like renal failure, active cancer, or antiphosphate, then you will change it. This is also known as direct oral anticoagulants. Don't forget. Low molecular weight heparin preferred in pregnancy.
That is means first line treatment for BE DWAC on general.
In general, first line of drug is direct oral anticoagulant, that is apixaban or rivaroxaban. First line of treatment.
On general?
Yes, in general, I'm talking about.
Okay.
We have a 22 years old male who is a driver, complains of shortness of breath, chest exercise 2 centimeters, pneumothorax, having no comorbidities, hemodynamically stable. Next step in the management is
Discharge with follow-up or
Discharge
forward.
with advice follow-up for the
no diving. Diving in the
No
sense,
diving also.
yeah, no diving should be there. This is also discharge, but you're not mentioning about diving. So mention about diving because he's a diver who dives, deep sea diving. He goes, he's a diver who has come in here. Okay. A patient presents with pleuritic chest pain. You decide to use well score for your further clinical management according to the score when to get an CTPA. This is from this question we're discussing from the last day. What question?
More than 4. More than 4.
So which one is the right option here?
2. 4 or more.
4 or
No.
5.
More
yes.
than 4, what they recommend. The score should be more than 4. So 5 or more, you have to select.
More than 4, yeah.
If it is 4, you don't get an CTPA done, you get an D-dimer done. So it is a
D-dimer.
tricky. Okay, they changed it a little bit. 4 or more. No, it is more than 4. More than 4 is 5 or more you need to select. Again, they have tricked a little bit while giving the options. A 50 years old gentleman presented with complaints of fever and cough, and weight loss is there since last 3 to 4 days. X-ray shows bilateral infiltrates as shown here, and there is an lymphopenia. Sorry, lymphocytosis.
HIV test.
So we are thinking of HIV here. There is a weight loss, bilateral
TB.
infiltrates are seen. So most likely this patient is having an HIV. So get an HIV test done in this patient.
Sir, 6 hours showing mirror TB, yes, sir?
See, that's why I'm telling it looks very much similar to miliary tuberculosis, but for UK purpose, you're not thinking about miliary tuberculosis here. Okay. For UK purpose, you need to always think of pneumocystis jirovecii because that is more common than miliary tuberculosis. For tuberculosis, classical X-ray where apical consolidation with cavitated lesion with travel to India. So classical history will be there.
Okay, thank you, sir.
This is an interesting question which had appeared previously. Many people got it wrong. This is the one what I was talking about. So basically on ABG, what is it suggestive of?
Chronic.
Respiratory.
Chronic type 2.
Acute and chronic type 2
Chronic type 2
respiratory failure.
respiratory failure.
Chronic type
Acute
2
and chronic.
because there is kidney compensation.
This is an acute on chronic type 2 respiratory failure. Okay, this can't, first let's go through the ABG. pH is less than 7.35, so it is acidosis. So we all know it is an acidosis. Then PCO2 is given as high, so it is in respiratory acidosis.
Yeah, oxygen is low. Yeah, صح.
PO2 is low. If PCO2 is high and
Yes,
PO2 is low,
PO2 is
we call it
acute,
as
yes.
an type 2 respiratory failure. Okay. Is it a chronic type 2 respiratory failure? Is it an acute type 2 respiratory failure? Or is it an acute on chronic respiratory failure? Or it is a metabolic acidosis with, respiratory acidosis within metabolic composition? This is wrong. Why it is wrong? It is not metabolic composition. It's an incomplete compensation what is happening because pH is still acidotic. So this one is a wrong option. Next, coming to whether it's an acute type 2 respiratory failure, carbon bicarb level should have been in the normal range. It is high, so it can't be an acute. Is it a chronic? pH is low, so it can't be chronic. So it is a mixture of that. It is an acute on chronic type 2 respiratory failure. So the right answer here is B. So is it clear?
Yes.
Again, why not is the wrong boss?
Why not?
Why number 1 is wrong?
It should be incomplete compensation.
But he didn't write complete also.
That's
So
why we will not select this one. This becomes more appropriate here.
So why it is chronic in this picture?
Chronic because bicarb levels are high.
Low.
But they didn't mention regarding how many days of presentation, right? So it can be a compensated one also.
Yes, it is. That's why it is an acute on chronic.
Okay, sir. Yeah.
Okay, it's acute on chronic we are talking about. It can't be just acute. It can't be just chronic. It is a combination of acute and chronic type 2 respiratory failure. So this becomes more appropriate. Here, if they would have mentioned an incomplete compensation, then 2 answers would have been right answers. They purposefully didn't mention incomplete here. Okay, they just mentioned metabolic compensation. So most appropriate and correct answer is acute on chronic type 2 respiratory failure.
Sir, it
Sorry,
means
sir, can
acute
you
and chronic.
acute and chronic respiratory failure, acute and chronic?
Yes, it is an acute on chronic respiratory failure. Okay, let's go for the next question here. Sorry. Okay, this is the next question. Patient with a history of right lobectomy presents to the emergency department with shortness of breath on examination, reduced air entry on the right side. Trachea is deviated on the right side. Heart rate is slightly on the high side. Blood pressure borderline. Saturations are 94% on 10 liters of oxygen, and there is an tachypnea. So what is happening here?
Tension pneumothorax. Tension pneumothorax.
Pneumothorax.
Yes.
Reduced air entry on the right side, and trachea is deviated on the right side. Trachea should be deviated towards the left side if you're suspecting intention pneumothorax.
So there is pulling of trachea.
Please mute.
Gent X-ray.
So let's
Next
rule
is
out
the
each
breath.
one of this. Can this be an
Breath.
infection? I don't know. Let's rule out each one of this. Can this be an infection? No. I don't know whether it's an infection or not. Nothing is here in the examination or history suggestive of an infection here. Can be very well an infection. Can it be a pneumothorax? Unlikely to be a pneumothorax. In pneumothorax, if it's a tension pneumothorax, this should have been deviated to the opposite side. So air entry is reduced on the right side. Trachea should have been deviated to the left side, not on the right side, left side. So pneumothorax, I'm not suspecting at all. If you're not suspecting a pneumothorax, then why to insert an ICD also here? It might be very well because of lobectomy, the mass has reduced, so the air entry is also reduced there, and so the trachea has also got pushed that side because of hyperinflammation of the left side of the lungs. So most likely this patient might be having an infection. So just get a urgent portable chest X-ray done and look what is happening, because we don't know, we are kind of clueless with the examination what they are given. So get an X-ray done, know what is happening there. Depending on the image, you can go ahead with the next step. So the right option here is chest X-ray.
Sir, according to the algorithm like ABCD, this patient is hemodynamically unstable, and also the PCO2 is less. So why not we starting oxygen in this case?
Because
Before
there is
the
no option to start on oxygen. They have already started on oxygen here.
okay, sir. Okay, thank you.
We have a sudden collapse while shopping came to the Indian ambulance. Patient is appendectomy 2 weeks back. This same question had repeated in last diet also. So the answer is 2D echo here. As we have discussed previously, 2D echo, the same question, same wordings had repeated again in the examination. After 1 hour of ABG treatment, pH is this, what is the indication to start? pH was, sorry, 7.1 here. Okay, again, in the option, they are not given the pH. So the right option here will be
BCO2, yes.
PCO2 levels. Okay, that's an easy question again. We have a 28 years old non-smoker present to the emergency of pleuritic chest pain at the hilar region. There is 3 centimeters. So we'll go ahead and we'll aspirate.
Yes.
This one, we are not sure what exactly the image is. Without image, it's difficult for us to really come to a conclusion. Okay, so question was something similar like this. If any one of you are given the exam previously and remember this question, please put it in the group or please tell me now so that all of us are benefited. This was a 45 years old male, came to the emergency department with shortness of breath, X-ray shows wide right lobe. This was the description given by the student who had attended the exam. Okay, what is the most probable diagnosis? Was it completely like this or not? We are not sure. Unlikely to be in hemothorax, unlikely pneumonia, still it can be, but we need exactly how the X-ray appeared. From this X-ray, it more looks like a soft tissue mass there. A mass, it looks like it might be an pancreas tumor or something like that. It looks like a mass, but we are not sure about this question. We're not sure about the X-ray also. If someone remembers, please put it in the group. We will share it with everyone, or you can personally message me, or you can tell me now.
Sir, can you please explain that if there is mass, the trachea should be deviated to the opposite side? Yes, sir.
It is not always the trachea will be deviated unless it is pushing to the trachea. It's not always necessary that trachea should be deviated to the opposite side.
Okay.
Okay, but we are not sure about it. The question might have more information. X-ray might have not looked like this because we are just picked up the description shows wide right color upper lobe, they told. So we just picked up something looking similar one. So it's difficult for us to really label. Pneumonia usually apical region, it doesn't cause mid lobes or lower lobes, usually it affects. Hemothorax, there will be blunting of the costophrenic angles, what we see, that is not seen here. Right upper lobe collapse can be an possibility, which usually appears like in white. Right upper collapse can appear like this. A soft tissue mass, very difficult to say whether this is right answer or not. Okay. Anyone has any doubts, you can ask me. This is the last question.
So can you explain the indications of NIV? Like what are the criteria, pH and PCO2 values should be?
For COPD, as discussed in the previous class, we had discussed about COPD, when to use it. Asthma, don't use it. Asthma, no. COPD, yes, you need to remember pH less than 7.35, PCO2 more than 6.5, respiratory rate more than 23, what you need to look out for. Next, we had discussed about using an NIV, that is CPAP, when to use it in an heart failure, you need to remember next one. Okay, if he has an acidosis along with severe breathing difficulty, you can use it immediately, or you can give medical therapy and wait for 1 hour. If there is no improvement after giving medical therapy after 1 hour, then you can start on CPAP. Okay, in coming up classes, we will see if we come across whenever NIV is required, we'll let you know the indications. These are the indications till now what we have come across.
Dr. Amin, about asthma, cardiac asthma patients, this should be the same for workup for the normal asthma patient or cardiac asthma?
See, cardiac asthma, when do we call it as a cardiac asthma? Does it mean it is an asthma, It's not asthma. It's nothing but pulmonary edema. It's nothing but heart failure, pulmonary edema. It is completely different. You will be treating like a heart failure. It's not asthma.
Okay.
Here we are not giving nebulizers itself. Everyone gets in furosemide. If blood pressure is quite high, then we are starting on NTG. Otherwise, not starting on NTG. Then oxygen, we are starting. If hypoxia, oxygen you start. Everyone gets in furosemide. High blood pressure gets an NTG. If not improving with the medical treatment, you will start on CPAP. So that is the treatment you're giving for cardiac asthma. Is an term which is not an asthma. It's a misleading term.
Sir, pulmonary
Sorry,
edema
sir.
patient. Sir, pulmonary edema patient with hemodynamic unstable. Oxygen first or furosemide?
Oxygen. You're going according to airway, breathing, circulation. We had already discussed in cardiac chapter. You can go ahead and have a look. Anyone has any questions from respiratory chapter, you can ask me.
Yes, please, sir. Actually, I'm not follow from the start, but you discuss respiratory failure type 1 or 2.
Okay. Coming to respiratory failure type 1. There's two types, type 1 and type 2. Okay. Type 1 is when only PaO2 is low. Okay. You have got an ABG done. On ABG, there is only PaO2 which is less. Then we call it, and here PaCO2 will be normal. This is type 1 respiratory failure. In type 2 respiratory failure, PaCO2 will be high. PaO2 can be normal or it can be low. So this is the difference between type 1 respiratory failure and type 2 respiratory failure.
Sir, acute and chronic, how to type to differentiate?
First, let's just see chronic. In chronic, pH will be normal. PaCO2 will be high. Okay. And
bicarb.
Yeah.
Yes, bicarb will be high.
Bicarb also will be high. Then it is a chronic. Acute. Acutely PaCO2 has gone high. So pH will go low because acidosis is happening low. Kidneys can't compensate immediately. So bicarb, either it will be normal or slightly on the higher side, or it might be high because it might be an acute on chronic. If it is a high, then it becomes acute on chronic. If it is high, then it becomes, so acute on chronic will be pH low, PaCO2 high, and bicarb will be high. So this will be acute on chronic. So this is the differentiation. If you want, you can write down.
Thank you.
So it's clear now. So any other questions you can ask me now. Important chapter, questions do appear. Questions do appear from well score, DVT, P, from pneumothorax, asthma, COPD. Surprisingly, questions don't appear from pneumonia. But curb score can be asked. So everything is important what we have taught you. If no questions, we'll stop the class now.
How many questions about ABG we should be exam?
1 or 2. 1. It's not that always comes on ABG. This time it appeared. Last day there was no question on the ABG. They had asked more indications for COPD when you start on NIV. So it depends.
Okay, thank you.
So we'll stop the class here. Thank you, everyone.
Thank you.